Hello everyone, welcome to another NP Academy lecture. Today we will talk about how to manage the asthma exacerbation in the emergency department. So we will talk about asthma, asthma, and we will only talk about the acute management of asthma. Acute management of asthma. We will not talk about the chronic management of asthma, as chronic management is significantly different than the acute management of asthma. And we will discuss about the adult patient. We won't talk about the peds patient, even though there are significant overlap between peds and adult patient the way we manage the asthma. And we will talk about the emergency department management. However, many of these concepts are also relevant if you are managing the asthma patient in the urgent care setting. It's very overlapping. And lastly, in the emergency department, you have a two kind of asthmatic patient comes. The one is something called a stable asthmatic, and another one is something called crashing asthmatic. This crashing asthmatic is a small group of patients who happen to be very sick. They are at the risk for respiratory failure. They may get intubated, and we won't talk about this crashing asthmatic. We'll talk about the stable asthmatic, the most common one, the bread and butter of emergency department. Okay, what we'll talk about today is that we'll talk about what asthma is, what are some of the sign and symptom for the asthmatic patient, what are some of the workup that you will do, how you will make a diagnosis, how you will treat them, and how you will make a decision to either admit or discharge the patient home. So let's talk about the asthma. Well, first of all, as you know, asthma is the disease of lung. So let's draw the structure of lung. This is a large airway called trachea. This trachea eventually branch out and it forms something called a small airway. And this small airway eventually open up into this alveoli. Well, asthma is the disease of this small airway. That's where the problem happen in the case of asthma. This small airway is made up of the cells called smooth muscle cells. This smooth muscle cells has the property of contraction and relaxation. And with this contraction and relaxation, these smooth muscle cells actually regulate the size of this small airway. And this contraction and relaxation is mediated by two different receptors. So one of the receptors that they have on the smooth muscle cells is something called beta 2 receptor. This beta 2 actually causes the relaxation of the smooth muscles. It relaxes it. And this relaxation actually increase the size of this small airway. Increase the size of a small airway. And then they have another receptor on the smooth muscle cell, something called muscarinic receptor. This muscarinic receptor, what it does it, this causes the contraction of a smooth muscle cells. Contraction. And this contraction actually decrease the size of this small airway. Size of airway. So that's how these smooth muscles actually regulate the size of this small airway. So what really happens in the asthma is that usually you have some sort of trigger. You have a trigger. And this trigger could be your URI, pollen, allergen, certain drugs like your beta blocker like propranolol. Some people are allergic to, sensitive to NSAIDs, and many things else. So those trigger, what it does is it does two things in the asthma exacerbation. First, it causes the bronchospasm. It causes the bronchospasm. And the other thing it does is it causes the inflammation. This causes your inflammation. So inflammation happens inside the air. That's where your inflammation happens, And the bronchospasm happen because of the contraction of this smooth muscle cells. Basically, those trigger cause the contraction of these smooth muscle cells, and it also causes inflammation inside the small airway, and the combination of these two actually leads to decrease in the size of this small airway, and thus cause a difficulty in breathing, especially when you are exhaling the air out in the expiration phase. So these two actually leads to difficulty in breathing, dyspnea. So when it comes to treatment, you treat the inflammation with the help of steroids, and you treat the bronchospasm with bronchodilating medication like your albuterol, like your apretropium. So these are the two main treatment for the asthma. So let's see where these medications work. And let's clear the board here a little bit to make some space. Here too, and then so your albuterol is the drug. The albuterol work on this your beta 2 receptor. Albuterol is your beta 2 agonist. It makes this beta 2 receptor work better. This is your short acting beta 2 agonist SHABA. And by activating this beta 2 receptor, this albuterol causes the relaxation of these smooth muscle cells and thus increase the size of airway. Apretropium, on the other hand, your apretropium, this apretropium work on the muscarinic receptor, and as I said that muscarinic receptor actually cause the contraction of these smooth muscle cells. Well, apretropium actually block the muscarinic receptor. Apretropium is your anti-muscarinic agent. So when they block it, it prevents the contraction of smooth muscle cells. Thus, smooth muscle cells remains relaxed, and that increase the size of this small airway. And your steroid that we talk about, your steroids work on this inflammatory inside the small airway. So this also, the combination of these three actually increases the size of this small airway and help breathe that improve this difficulty in breathing. Sometimes we also use this other drug called magnesium sulfate. This magnesium sulfate actually, this also relaxes the smooth muscle cells and help increase the size of airway. But magnesium works a little differently than albuterol. Albuterol works on the beta 2 receptor, but magnesium relaxes the smooth muscle cell by different mechanism. Okay, so if you are studying for NP board, something to know here that these changes in the small airway, in the asthma exacerbation, these bronchospasm, this inflammation, these are completely reversible. NP board love to ask this question. So these changes are completely reversible because there is no permanent underlying damage to lung tissue in the case of asthma, which is different in COPD. In the COPD, there is permanent damage to the lung tissue. The COPD is kind of irreversible, while asthma is reversible. Okay. So after this is how what asthma is. This is how we treat it. So let's see how the patient will present to you. What are some of the sign and symptom of the patient when they come to emergency department? Well, the number one is the wheezing, as you probably know. Wheezing. They may have a cough, plus minus sputum production. Sometimes they can have a sputum, sometimes they cannot. They may have some level of difficulty in breathing. Sometimes they may have some use of SST muscle. And there is a spectrum of it, but these are some classic finding on the asthmatic patient. Well, something about wheezing that we should talk about it. First of all, somewhere somebody has started that if you are wheezing, that means you have asthma. Well, that's not true. Not all wheezing are asthma. Not all wheezing are asthma. There are a number of other diseases that have a wheezing and that's not your asthma. For example, PE, pulmonary embolism. Roughly 1 out of every 10 patients with the PE will have some sort of wheezing, and usually this wheezing are focal wheezing, maybe one side of the lung. Other condition that can have a wheezing is your pneumonia. Is your CHF can have a wheezing. Foreign body ingestion can have a wheezing. Just so you know. So it's very important to know these things. Okay. Other thing to know about here when we are talking about the sign and symptom, we should know what are some of the sign and symptom of this crashing asthmatic so that we can act accordingly. Even though we will not talk about how you manage the crashing asthmatic, we should definitely know how to differentiate it so that you can act accordingly. So the sign and symptom for this crashing asthmatic is your number one, your diaphoresis. Diaphoresis. If asthmatic patient is breaking out in sweat, that's the bad sign. That means that patient is at the risk for respiratory failure. Uh, if they have this something called silent chest. It's like if you listen on the auscultation, you don't hear anything, no wheezing, no air movement. It's like you feel like your stethoscope is not working. Sometimes you have to tap on the diaphragm to see if it's working or not. That silent chest is a sign of crashing asthmatic. This patient is at the risk for respiratory failure. Altered mental status. Altered mental status. This means these patients are they are having this air hunger. They are suffocating because of lack of air. The altered mental status in COPD is different. In the COPD, that's because of they are retaining the CO2. In the asthma, it's the air hunger, it's a suffocation. If you cannot speak in full sentence, they speak only in words. That's a sign for crashing asthmatic. Speak in words. The heart rate of more than 120. Remember, the tachycardia is more than 100. But if the heart rate goes above 120, that's a sign of crashing asthmatic. If the respiration rate goes more than 30, these are your sign of crashing asthmatic. Interestingly, though, roughly 50% of the crashing asthmatic may not have any of these signs. Just so you know, it's kind of very unfortunate. But if any of the asthmatic patients have any of these symptoms, be very alarmed and careful because these patients may be at the risk for respiratory failure. Okay, so after this, let's talk about what are the workup that you will do for the asthmatic patient. Well, generally speaking, if the patient is stable and have a documented history of asthma, you really may not need any lab work or any imaging. And I do a lot of time once the patient comes, we know that this patient has a history of asthma. Now they are having asthma exacerbation. We give them some treatment. They respond well. You don't need any lab work, any imaging, nothing. But in some times, so in certain patient population or in certain medical certain conditions with a certain presentation, you may want to do some sort of workup here. And the one that you will do the most commonly is a chest X-ray. And sometimes you may want to do CBC or CMP depending on, ABG, you do not need ABG. Back in the day, ABG used to be the standard of care for the asthmatic patient. Turn out you don't need it. All you need is the pulse ox to measure the oxygen. That's enough. Okay, so when do you need the chest X-ray? Well, if you're worried about pneumonia, if you have any reason to believe that maybe they have a high grade fever or something. In this setting, you want to do chest X-ray, you may want to do some CBC. If you have suspicion for pneumothorax, if the patient is having a pleuritic chest pain, pneumothorax, you may want to do chest X-ray. If the patient has a forced wheezing, they never wheezed before, forced wheezing, you worry about this. You may want to do some imaging or lab work. If you give the treatment to the patient, and they are not responding to treatment, no improvement with the treatment, in this setting you may want to do some lab work or imaging to see what's going on. Hypoxia, generally speaking, asthmatic patients, they tend to be not hypoxic, but if they are hypoxic, you may want to do some X-ray or imaging. If you are admitting the patient, in this setting, we want to do some lab work. You are admitting the patient mainly because they didn't respond to the initial treatment. If the patient who has a multiple comorbidities, say for example somebody has a history of CHF, just so you know, when you treat the asthma with the albuterol causes the hypokalemia, and in the general healthy patient, hypokalemia caused by albuterol treatment, you don't want to treat it. You don't want to fix the hypokalemia because those are transient. It fixes on its own. On the other hand, if somebody has a history of CHF and they're on the diuretic, so they're already at risk for the hypokalemia. Then you give them some more albuterol, then you can drive the potassium really low, and that you can put them at the risk for the arrhythmia. So something like this, you want to do some lab work. You want to put them on the monitor if you're giving them treatment, just to keep eye on their heart rate and the rhythm. So these are some of the situations that you may want to consider doing some lab work and the imaging. The other high risk group is your drug user. Not only the people who snort the drug, even the IV drug user, they tend to have a worse prognosis in this case. And the argument here is that people who uses the drug, they don't reach out to medical care on time. By the time they get to the medical care, they are usually pretty sick. Anyone who has a previous history of intubation, they are the really high risk for morbidity. They have a poor prognosis, so keep that in mind. So these are some of the situations that you may consider doing some lab work, but generally in the lot of the patients who are healthy, has a documented history of asthma, you really don't need any lab work. You can just treat them and send them home. Okay, well, how are you going to make a diagnosis? How you diagnose that, okay, this patient is having asthma exacerbation? Well, diagnosis is purely clinical. You make a clinical diagnosis. One thing you definitely want to know is that you want to establish, does this patient has history of asthma? If the patient does not have a history of asthma, then it will be a little challenging that you're going to diagnose them for the very first time that this patient is having asthma exacerbation. So something to talk about the patient, either you can talk to the patient or look into the chart. Does the patient knows about something called albuterol? That the patient has been treated with the asthma exacerbation in the past? Does the patient knows about that? Hey, he or she take the 5-day course of steroid in the past, or and have they done something called peak flow, those kind of things. If the patient knows those things, that yeah, hey, I have the asthma exacerbation in the past, I have treated with albuterol and the NIP treatment and the steroid, that means yes, they have a history of it, and now they came to you in the ED, they are wheezing, have difficulty in breathing, then you can easily diagnose them yes, this is the asthma exacerbation. So keep that in mind. So once you diagnose them, then the last part comes down to treatment. How are you going to treat the asthma? Treatment is rather very simple, straightforward. First of all, you want to give them oxygen only if they need it. As I was telling you earlier, a lot of times they are not hypoxic, they may not need the oxygen. But the goal here that you want to keep the O2 sats more than 92%. And if the patient is pregnant, the pregnant patient, you want to keep the O2 stats more than 95%. So that's the one thing. The second thing that you want to do, that you do want to do some sort of lung function like peak flow. Only if it's possible, if the patient is they're alert and active and alert enough that they can cooperate in this thing. So this is not essential for every patient, but if the patient is too sick, you may not get it. But if it's possible, if you think the patient will cooperate to you. And the idea for peak flow is not because you are looking for a specific number, but idea here is that you want to get the pre-treatment before you start the treatment, pre-treatment, and after 1 hour of post-treatment, 1 hour post-treatment. And what you are looking for the peak flow, you want to see at least 10% improvement in the peak flow after 1 hour treatment. That's all matter. That means that patient is going into the right direction. If so, again, the peak flow will be conditional if it's possible. Then the drug of choice for the asthma is your albuterol. You give them albuterol. And how much? You can give them a lot of albuterol. And how often? You can give them as often as you want. It's a very safe medication, and there is no drug, there is no treatment has been proven to be better than albuterol. Okay, so usually in the emergency department, you give them the albuterol via NIP treatment. NIP treatment. That's the standard of care these days. One of the drawback of NIP treatment is that, as you know, that it forms the smoke and patient inhale the smoke. In that setting, patient does not get all the drug in their lung. So maybe when you give the albuterol through NIP treatment, they may get maybe 30% of the drug. The rest 70% goes into the air. So that's one of the drawback for the NEP treatment. So for the NEP treatment, the usual dosing for albuterol is 2.5 milligram to 5 milligram per treatment. One thing to know about when you manage the asthma and when it comes to the diagnosis and treatment, that you're going to make a lot of clinical decision based on the patient presentation, your physical exam finding, and your own judgment. So, like this dosing here, sometimes you can use the 2.5 milligram, sometimes you can use the 5 milligram. I have used both depending on the how the patient look. Sometimes I can use only 2.5, sometimes I feel like the patient is too sick, I give them 5 milligram. That's the one treatment that you want to do. The another one that you want to add is that you want to add ipratropium to it. Ipratropium. They found that treatment of the asthma with albuterol and ipratropium together, they have a better outcome and less hospitalization compared to only albuterol treatment. So the dosing for ipratropium is 0.5 milligram per treatment. One of the drugs that I use in the emergency department is something called Dionab. Dionab has 2.5 milligram of albuterol and 0.5 milligram of ipratropium. So sometimes I just give them a 1 DNAB treatment, just 1 DNAB, and sometimes if I feel like I want to give them a 5 milligram of albuterol, then I order 1 DNAB treatment plus I add 2.5 milligram of albuterol. So this is the usual treatment. Okay, well, how often you want to give the treatment? The rule is that within the first hour, you want to give them at least 3 treatments. So Q 20 minutes. So you want to give them 3 treatment in the first hour, then you reassess. Okay, well, sometimes we do something called continuous treatment. We do the continuous treatment for 1 hour. And again, this intermittent treatment versus continuous treatment, that will be some clinical decision that you will make. Some of the new data shows that the continuous 1 hour treatment, this tend to be more effective and cause less hospitalization compared to this intermittent treatment every 20 minutes and the 3 treatment. And usually, so you definitely want to do the continuous treatment if the patient had been taking the albuterol inhaler at home before they come to ED, or they've been using the NEP treatment at home before they come to ED. So I use continuous treatment a lot, rather very often. Only time I use the intermittent if I feel like patient is really not sick, very stable. But the continuous treatment, I found it very effective. And usually the dosing for the continuous treatment is that you give them albuterol of 10 to 15 milligram and ipratropium you gave them 2 milligram. So what I do is that I still use this. I use the Dionab. I use the Dionab for the continuous treatment, Dionab, and just I order 4 vial of it. So this 4 vial of the Dionab will have like 10 milligram of albuterol and 2 milligram of ipratropium, and that is good enough. It worked really good. I found it very effective. So these are the treatment in the first hour. Then the another thing that you want to give them is this was the number 5. Let's talk about number 6. Is that you want to give them some sort of steroid, and there are a lot of debate which steroid and how you want to give them. And this again, you're going to make a clinical decision. If the patient is really stable, not that sick, I usually give them prednisone somewhere like 40 to 60 milligram PO. I never give them less than 40 milligram. I found that less than 40 is not very effective. So that's the usual. If I feel like patient is really sick, we got the IV, some lab work, and if they have IV, in that case, I give them Solomedrol. I give them IV, and the dosing is sometimes 1 milligram per kilogram, or sometimes I give them 40 milligram, Sometimes I give them 80 milligram, sometime 125 milligram, sometimes I give them 60 milligram. It really varies. By the time I give them 125 milligram, this one I feel like the patient is really sick and they get admitted. But this decision of dosing between 40 versus 60 versus 80 is all clinical. But you want to give them steroid, and you want to give them steroid within the first hour, when the patient comes to the ED, because they found is that if you give them steroid early, it reduces the rate of hospitalization. So that's the usual treatment that you want to give within 1 hour. Well, after 1 hour, what you want to do, after 1 hour of this treatment, after 1 hour, you reassess the patient. And if the patient still have significant wheezing or some difficulty in breathing, then you can give them magnesium sulfate, 2 gram over 15 to 20 minutes, and you give them IV drip. You never push it, you always drip it over the course of 15 to 20 minutes. It's very effective. It also causes the bronchodilation and help. And if it's not effective, if it's not getting patient still have some symptoms, you can give the repetitive dose for albuterol for additional 1 to 3 hours PRN as needed. However, if the patient is improving, then you make a decision to send them home. So after 1 hour, you make a decision. If they need a more treatment, you continue to do another for 1 to 3 hour treatment, and you can give them the DNF treatment every 20 minutes, every 30 minutes, as is all the clinical judgment. And after additional 1 to 3 hour, if the patient is improved, you send them home. But if they are not improving, then at that time, you want to admit the patient. Okay, if you do decide to discharge the patient, something that you want to make sure when you discharge the patient, you want to make sure that tachypnea has resolved. Tachypnea has, like, they have no tachypnea, they have no work of breathing, no work of breathing. They have no hypoxia. Hypoxia has resolved. Sorry, here we're gonna do no hypoxia. And overall, you want to have the feeling that the patient does look good to you. This clinical judgment. Otherwise, you can just admit the patient. Other thing that you want to go, when they discharge the home, you got to send them home with some steroid. And usually you send them home. I send them the prednisone, usually oral, PO 40 to 60 milligram for 5 to 7 days, and they take once a day, daily. My go-to is that I send them home with a 40 milligram once a day for 5 days. They should also be getting some steroid inhaler. Either you should send them home from the ED, or I usually ask them to make sure to follow with the doctor within the 5 days so that they can put them on some steroid inhaler. So these are the usual treatment. Well, do we need to give them antibiotic? The answer is usually not. The antibiotic doesn't found to be any effective. Only time you give the antibiotic if you have any reason to worry about the bacterial infections. For example, if the patient has a pneumonia, if you worry about the bacterial sinusitis. So in this casing, antibiotic is okay. But as long as you feel like there is no bacterial infection, you really don't need the antibiotic, not even Z-Pack. It doesn't help. Well, this is all about asthma. I hope you find it useful. Thank you very much, and I will see you next time.